what you need to do is see that, no, the goal is that depleted feeling. Try to aim for depletion. And I remember asking him, have you ever seen someone who aimed for depletion and they go to work and they're walking around and they just totally poop out and then they're lying on the floor, totally depleted? And he laughed. He's like, well, no one ever does that. I'm like, yeah, the more you aim for depletion, the more you aim to bring on the tired feeling, the more it recedes. It's like getting a second wind. So that's what you aim for in your work.
Before we get started, if you enjoy these episodes, you might want to check out more at OptimalWork.com. Our website offers unique content, tools, and exercises to help you thrive at work and beyond. We have an in-depth masterclass covering our entire theory of growth, daily recommendations for personalized advice, and a platform to help groups and organizations learn and practice optimal work together. You can get a free trial at OptimalWork.com. Now let's start the episode. Hey, this is Sharif here with another episode of the Optimal Work podcast, joined by Dr. Kevin Majors. Kevin, good to be back here with you again.
Sharif, thanks for having me back.
Yeah, Kevin, excited for our next episode in the depression series, and it's been quite the ride so far. And we're here to, kind of our one of our first climaxes here of putting, a synthesis, putting everything together. Well, where should we start?
So we can start with the core insight that in a way began the whole series. And that is that there is this parallel between panic disorder and depression. And panic disorder is best understood as a phobia of adrenaline itself. So adrenaline can be good energy, where you're just really riding on the wave of excitement, performing at your best, or it could be anxiety, which you could call bad energy. And it's the same then with depression. Depression is a phobia of adenosine itself. And so you can have good tired or bad tired. And panic disorder converts all energy into bad energy. Because all adrenaline, you have a phobia of it, it starts to be experienced as something bad. And similarly, depression converts all adenosine into bad tired. So it shifts, that's not just a metaphor, it actually shifts the brain to type 2 dominance. So it'd be nice for us to unpack a little bit these parallels. I think it's actually one of the most elegant parallels in all of psychiatry. And in the end, it shows why the treatments for both are essentially the same.
So am I right in that you can think of adrenaline and depression as kind of opposites? And these are the two dominant problems that people can run into psychologically. Those are like the two main themes of psychological disorder.
You said, I think anxiety, you mean. So you have
What did I say?
Anxiety, adrenaline.
Oh, yeah, I meant anxiety. Thank you.
Exactly. Yeah. So anxiety and depression are the mainstay of all therapists in the world. This is what we mostly end up treating. This is together the vast, vast, vast majority. And there's always been seen to be a big overlap. I had the good fortune of being trained in CBT by Robin Jarrett, who is a real powerhouse in studying cognitive behavioral therapy for depression. And I remember her joking that if the same person, if they go to a medical center in Dallas, they get diagnosed with depression. And if they go to a medical center in Boston, they get diagnosed with anxiety. So she actually thought that there's this underlying commonality, which is like the cognitive behavioral therapist in her coming out, to how these things, like whether you say a person has anxiety or depression, they have so much overlap. And I think that now as we're unpacking what's going on with depression, it'll become more clear why there's so much overlap.
That's great. And yeah, it's so interesting because anxiety being about energy and depression being about tiredness. So there's clearly a relationship there. So good. Well, Kevin, I guess let's, dive into the parallels here, as you mentioned.
Well, maybe one thing to see in how these both work is that you go from fear to amplification to a spiral. Okay, now in panic disorder, the way that works is the person has a fear of certain bodily sensations. Uh, in psychiatry, we call your perception of bodily sensations interoception. So panic disorder is considered an interoceptive phobia. And that means that you're afraid of particular bodily sensations, particularly the ones associated with adrenaline itself. So that would be things like increased heart rate or tightness in the chest or sweating or having like being a little tremulous in your muscles. So those are all things that adrenaline brings on. So what happens then if you have a phobia of your heart rate suddenly racing? This happens when people are afraid that they're having a heart attack. The thoughts that accompany panic are usually I'm dying or I'm losing my mind. So it kind of depends on what symptoms are most associated, with the initial triggering of their panic. But suffice it to say that there's a phobia of a sensation that is brought on by adrenaline. Now, here's the problem. The more unwilling they are to experience it, the more they're avoiding it, the more those sensations are labeled as threats. And the amygdala will respond when you detect them by dumping out more adrenaline so you can handle the threat. That's part of your fight or flight response. Okay, so that amplifies the initial anxiety you had then. So it's like maybe your heart starts racing, you have a little palpitation, like, what was that? You get a jolt of adrenaline. Well, that can make palpitations worse. That's one of the symptoms, or it can make your heart race more, or your chest can get more tight. Okay, and then you get into this spiral of amplification. The more concerned you are, you can suddenly skyrocket in anxiety. And so you can go from zero anxiety, or no one's ever at zero. Usually people are like a 2 or 3. You can go from like a 2 or 3 in anxiety suddenly to a 10. And that's the mark of a panic attack. And it's because it's self-amplifying, and then you get into the spiral. What I think is fascinating is that depression follows the exact same pattern. Okay, but it's a little different in the time course. So in depression, you have a phobia of the sensations that adenosine brings. And that could be feeling exhausted, feeling a sense of heaviness, kind of a depleted feeling. Okay, so when those sensations come, and they will inevitably come at some point, your amygdala responds. But in this case, because the threat is something that is inescapable and omnipresent, your amygdala does not respond in the same way with adrenaline to handle the immediate overcoming of it. Instead, it gives you cortisol. Well, not the amygdala, but it leads to the release of cortisol, right? But that ends up amplifying the sense of bad tiredness all through your system. So in this way, you could say that any tiredness gets converted to bad tiredness. So when you have then, when you start noticing then that there's this bad tired feeling, it feels even more inescapable. It feels even more omnipresent. And that triggers more fear, which triggers more cortisol. So you end up getting caught in a vicious cycle where there's a feedback loop, where the sensations, when they occur, end up triggering the very things that worsen them. But in this case, it's not the sudden spike of adrenaline, but it's more kind of slow crushing effect of very high cortisol. The purpose of cortisol is when you're in a state of inescapable threat, what we call thwarted escape. Your amygdala, in a sense, is on the side of getting you demotivated momentarily so that you can think of another way of approaching it. So you don't just wear yourself out trying to do something that isn't working. So the type 2 adenosine system, which cortisol tips you down into, that actually has a protective function to it. But you certainly don't want any tiredness suddenly then getting triggered, pressing on the type 2 system and giving you this total type 2 dominance. So that's like the broad overview. There's an initial fear of a sensation, and then it gets amplified, and then you spiral.
Mm-hmm. And now, Kevin, one thing I believe you mentioned when we've talked about anxiety and panic in the past is that I guess with anxiety, you have fear of a situation, but then you mentioned that that's usually fear of an emotion, like fear of public speaking might be fear of embarrassment, actually, or shame or something like that. And then it becomes full blown panic when it becomes fear of adrenaline itself or fear itself, right? So then that's where you get this really vicious cycle of this spiral, as you called it. Is there a similar thing with depression and tiredness and adenosine, that there's this, tiredness or depression with respect to a situation first, and then, but that's really some emotional thing. And I don't know, are there like concentric circles in the same way as with anxiety?
Yeah, that's a very good point. So in anxiety and depression, it's well known that you can start with a specific trigger that then generalizes. So when it gets to be full-blown panic disorder, it's generalized because it now attaches to adrenaline itself. All right, so then you can get really frequent panic attacks. Probably 1 in 10 people have actually had a panic attack, at some point in their life and didn't really know what caused it. But only in maybe 1 in 10 of those does it become a full-blown panic disorder, right? So there's probably a lot of reasons why some people might be more vulnerable to the single occurrence of a panic attack out of the blue, triggering now the repeated occurrence of them out of the blue. Probably the more stress people are under, or the less support they feel, or their own, maybe there's other fears it plays into, like, oh, can other people tell I'm panicking? It's one of the interesting things when you have group therapy for panic disorder is at the end, they'll ask, "Hey, so how many people here had a panic attack during the group session?" And a number of people will raise their hands. And it's always the case that no one ever could tell. So they get over the idea that, oh, this is really embarrassing. It's obvious to everyone what's happening, even in a group just for people with panic disorder. That doesn't happen. So there's probably a lot of reasons why you go from this one-time event, again, which is 1 in 10 people, to where then 1 in 10 of those actually have the recurring thing. And probably you see something very similar in depression. Any sudden disappointment, any sudden loss of a bond can cause a momentary tilting into type 2 dominance. So, because if you get left in a prolonged way in threat mode, which is what happens, suddenly there's a loss or a bond is disrupted, a bond that had been keeping you more in the safe love mode, uh, you can experience then a loss of meaning, and with that meaning engine taken offline temporarily because you're now in threat mode, then you're going to have, again, a loss where effort becomes harder and more punishing as type 2 dominance gets established there. And then finally, in your thinking, you're going to be more likely to ruminate, about the loss. And you get into this looping that happens, which causes more type 2 dominance in the cortex. But in some, then, it becomes more generalized, where they so dislike the type 2 bad, tired feeling that they're so on the alert for it that now it gets triggered more and more. Here's just another way of throwing it in to go a little bit one step deeper. Um, the molecule of unwillingness is dynorphins, and that plays the crucial role in amplification for both adrenaline and adenosine. So I actually like to say that anxiety is simply adrenaline plus dynorphins. And depression is adenosine plus dynorphins. So what happens once the feeling of tiredness, the feeling of adenosine, even good tiredness, once you're unwilling to experience it, which is what happens when you are avoiding it like it's a threat, once that unwillingness attaches to it, you are going to tilt the entire system even more powerfully into type 2 dominance. Because dynorphins cut off dopamine, which are what shield you from further type 2 dominance. So if you're tilting already into type 2 dominance, which cortisol will do, as we talked about in burnout, adding dynorphins on top of it, where now dynorphins are brought on by adenosine itself, this would be the theory, just further than cements you in total type 2 dominance. And that gets people even more stuck, even more locked, where now their thinking is even more constricted. It's harder to be creative. It's harder to be flexible. There's a lot more cognitive looping going on. And they feel like they're just isolated and stuck in thread mode. So that's what we're talking about. Yeah, that endorphins push you that way.
Before we continue, a brief message. If you're benefiting from these discussions, please take a moment to hit like and subscribe. Doing so helps us to reach more people. So you're not just learning, you're also helping others to discover a path of growth and flourishing. Thanks for your support. Yeah, so if dynorphins are, I mean, just to apply this to my current situation. No, if say it's the afternoon, and I'm starting to get tired, maybe I had too big of a lunch. Okay, big mistake. And but I have some important things to take care of. So I start getting tired, and I'm unwilling to feel that tiredness. So that's going to bring on dynorphins and is going to tend to flip me into bad tired.
Dynorphins will amplify whatever you are unwilling to experience. So that's the crucial insight. That also points then to the treatment. The treatment is willingness, because that is the only thing that will change the dynorphin attachment. The way you kind of peel off dynorphins from anything is willingly experiencing the thing. That means welcoming it, even savoring it. And the height of willingness is love, like passing love through it in some way. So now when it comes to the treatment then for panic, it all comes down to willingness to have adrenaline, so that the person, when adrenaline starts coming, can welcome it, can savor the sensations rather than hating them. And then some way see that this is actually, they can embrace this fully. And so you help them to see that it's worthwhile learning to embrace adrenaline, ultimately because then you can use it. So if you can learn to take bad energy and flip it into good energy, then you are cured of panic disorder. So the interoceptive exposure therapy for panic disorder is simply bring on the panic attack. And you do that through hyperventilation. And as a person brings it on pretty reliably, you will have this building of anxiety that gets higher and higher and higher. And at some point, I have the person pause, welcome, so they can stop hyperventilating and just practice willingly welcoming the sensations that come. And then you do it again. And then once their anxiety gets up to a 7 or 8, I have them breathe normal again and welcome the sensations, savor the sensations. And you keep doing that, and it becomes, even within one session, very hard to get the sensations to come back. The key is willingness. Now, willingness is a striatal phenomenon, which means it is what governs effort. And so when people relapse in panic disorder, it's because they start expending effort in the service of unwillingness. They start doing things to try to prevent panic from happening. They try to somehow hedge their bets and play it safe. The more effort starts going towards unwillingness, the more dynorphins will attach to adrenaline again, and the more it comes back. So every relapse in panic is actually a relapse of unwillingness coming back. But the cure is also the same. It's just you willingly welcome it again. And with depression, it's identical. So if you think of depression as an interoceptive phobia, a phobia of the sensations brought on by adenosine, so that all tired becomes bad tired. Well, the solution to that is actually good tired, to willingly experience the sensations of adenosine. So for that, exercise and focused work are the two best treatments, because they can reliably bring on adenosine, but then you momentarily feel it, and you get to practice willingness. But it's also great that people see anytime they feel tired. And often with depressed people, it's right before the first hour of work. Just as they sit down to work, they can get the wave of aversion to the tiredness and depletion that will come. So that's the moment then to practice pausing for a minute or two to savor the sensations, to see that, no, I'm going to really set a challenging goal in this next hour of work that will bring on a good tired feeling. So we actually have them aim for tiredness. So I remember once back when I was in Dallas and I was working with a patient who was getting depressed, and he had in fact gotten over panic attacks. And then as the depression started coming on, unrelated, he came back after having not seen me for some time. Uh, I explained to him, this is identical. So this is the same exact thing. What you need to do is see that, no, the goal is that depleted feeling. Try to aim for depletion. And I remember asking him, have you ever seen someone who aimed for depletion and they go to work and they're walking around and they just totally poop out and then they're lying on the floor, totally depleted? And he laughed. He's like, well, no one ever does that. I'm like, yeah, the more you aim for depletion, the more you aim to bring on the tired feeling, the more it recedes. It's like getting a second wind. So that's what you aim for in your work. And it was like this aha moment. And he was it was the fastest flip out of depression, actually, that I've ever seen. So this, long time ago, it was more, this was like almost 20 years ago, that the kind of I had a proof of concept, of the idea. But really it's just translating in, an understanding of behavioral therapy for depression, which is called behavioral activation, which is bring on tiredness. The more, the better. That actually is the cure.
Well, Kevin, it makes a lot of sense. And, one thing that we've always said regarding anxiety is that you need the alarm to sound in order to be able to work on it. So it makes sense because the alarm or the amygdala, when the alarm is sounding, then it's watching your response and then it's learning from your behavior. So I suppose something similar is going on here with tiredness, is that you actually, in order to shape your response to tiredness and your habitual response to that, you need to actually bring on the tiredness so that you can learn from your brain can learn from your response to it.
Exactly. And this makes sense from just a purely behavioral understanding of what's happening here with depression, that it's all about unwillingness. And so willingness is the cure. Right? But what's fascinating is that it even can perhaps explain how other antidepressants work. So it seems that type 1 adenosine tone is antidepressant. So the more you can amplify type 1 tone, the more antidepressant effect there is. Type 2 adenosine tone is prodepressant. So it's actually depressing, right? And the more that gets amplified, then the more depressed the person is. So there is, I've seen theories that one of the findings, it's been said, of people who have done electroconvulsive therapy, ECT, which is the most effective treatment for depression from a biological standpoint. So ECT is more powerful by far than any antidepressant. It has side effects, like one of the things is memory loss. So, but it's just interesting to see that, okay, ECT is the most powerful antidepressant that we have. And it may be that ECT has its effect by resetting the type 1, type 2 adenosine balance. And that what you get from the seizure is a powerful reasserting of type 1 receptors, so that now type 1 tone is strongly amplified. And then a downgrading of type 2 receptors. Now, this is all very preliminary, but they've apparently, there is evidence that this could be happening in ECT. So if one of our most powerful treatments could work through this mechanism, it would just be another fantastic proof of it. But we already have the behavioral proof, because the most proven treatment overall for depression is behavioral activation. And everything in behavioral activation is about rhythmically stimulating type 1 with periods of rest alternating, so that you get a strong type 1 signal, but then it goes off so that you never spill over into type 2. Remember, the type 1 receptors, they fill first. And then once they're filled, then the type 2 receptors fill. So it could be that people who are prone to depression have, in fact, they might have, for instance, fewer type 1 receptors available. So they go more quickly into type 2. And then maybe in certain people, something like ECT or even antidepressants could replenish the expression of type 1 receptors. So that now when you get the good tired feeling, you get a stronger good tired feeling. And you don't ever have to get into the bad tired. But this is all getting into the deep workings of it, but it's fascinating as a direction for psychiatry to be moving, to be really, I hope the field in the next 5 to 10 years can make progress in an adenosine theory of depression, because it's the most actionable. It's the most hopeful one that we have.
Yeah. Kevin, on this topic of rhythm, sorry, just to fill out the picture for me. I mean, would you use that with anxiety too? This idea of rhythmically activating your adrenaline system, just to see where the parallels are.
Yeah. So the reason that it needs to be rhythmic in depression is because you have this system, this type 1 system, that we know responds best and builds up the good tired feeling only with what's called phasic stimulation. So that's why if you are building up adenosine in just a constant way, for instance, that's what happens in marathons of work. You're just building up adenosine and it's constant. So in a marathon of work, you lose the rhythmicity of it. So it ends up then that after 90 minutes of work, you start going into type 2 territory because you've essentially filled what your type 1 receptors can handle. So the rhythmicity is how you then work down adenosine so that it will just activate type 1 receptors.
Adrenaline doesn't have that like build up
Adrenaline doesn't have
sense,
that
though.
because adrenaline's receptors, you could think of it this way. In panic disorder, adrenaline, the sensations that are seen as a threat, those are the peripheral receptors for adrenaline that are receiving it, not the central ones. So it's true that in panic disorder, you still have 2 different receptors, that for adrenaline. In the periphery, when those ones are activated, you have all the symptoms of racing heart and shortness of breath and all of that. The central ones are in the brain. And so those then is technically noradrenaline, which is essentially identical to adrenaline. And so when noradrenaline is working in your brain, then you experience all the good effects of good energy. So good energy, bad energy is really, good energy is inside the brain, and the bad energy is when it's stuck in the periphery, not being used by the brain. So there reframing actually allows the brain now to have the surge of adrenaline within it. It's a different mechanism, but it's not that you have like receptors in the same area receiving, and it's just like a matter of quantity. So that's why rhythmic doesn't matter. What matters is framing.
Fascinating. So, well, Kevin, we're basically out of time here for this episode, but I don't know if you had any. It's great to see these parallels, the new theory of adenosine and depression, paralleling to anxiety and adrenaline. But I don't know if you have any final thoughts you want to leave us with here on this episode before we continue the discussion on depression next week.
Yeah, maybe just that in both cases, you can learn to flip from a state of bad energy or bad tiredness to good energy and good tiredness. And that means getting yourself willing to experience the very thing that you were dreading. Willingness produces the flip. So in a way, the flipping is under voluntary control. If willingness isn't voluntary, nothing is. So the more willing you are to experience the thing that had seemed like the worst thing ever, the more you fundamentally change how your brain processes that thing. So that we can say that, in fact, the cure for bad tired, and particularly in depression, the cure is good tired, and learning how to aim for that and to bring it on. But to go deeper into that, we probably need to go a little deeper into how we apply the 3 levels of meaning and effort and attention in helping people through depression.
Well, I think that'll be a great theme for us to focus on next week. So Thanks so much, Kevin.
Thank you, Sharif.
All right, we'll be back next week.
Thanks for tuning in to today's episode. If you enjoyed our conversation and you're looking for more in-depth guidance, check out OptimalWork.com, our unique platform that delivers content, tools, and exercises to help you thrive at work and beyond.